Just a brief introduction. Hopefully my slides are moving. Yeah. So I'm going to go a bit through terminology. I've been asked to talk from the endocrinology side. So I'm an endocrinologist in Oxford. I'm going to explain a bit about what hormones are, how they work and help our body, the role of an endocrinologist, which is the title given to doctors that have an interest in hormones, but also our role in the MDT within the neuroendocrine tumor or neuroendocrine cancer kind of package, which is what obviously we're here to discuss today. And then specifically, I was asked to talk about hypersecretory states. That means making too much of something, so secreting too much. So hyper always means more than. And the ones that we've picked are around paragangliomas and a few others that I've mentioned, but we'll see if you've got any questions towards the end. And depending on how they go, if the questions are very relevant, do just butt in and ask. I think words and terminology are really difficult in neuroendocrine tumors, partly because doctors don't like using the word cancer, and we use very different words. So we'll use neuroendocrine tumor, mass, lump, lesion, and that kind of all moves around. So I'm sorry if I flick between the word tumor and cancer. I personally do use NET as an umbrella term, and that's the abbreviation I'll use through the talk. A tumor basically to a doctor means an abnormal mass of tissues, so a group of cells that have divided too much and shouldn't be doing that. And then it's an umbrella term for it can be benign or it can be malignant, and they're kind of used differently. So malignant to us means it can spread somewhere, whereas benign means a lump that's there that shouldn't be there. So I think all of these words are sometimes used quite badly by doctors and spread between. So I'm just going to admit that I am one of those people that can use those terms interchangeably. I think it's important to recognize that cancer is really common. So about 50% of us will have cancer of some form in our lifetime, and there's hundreds of different types. And although you're all on this talk today from the neuroendocrine cancer patient group, actually your cancers might be slightly different. So I might not say something that's specific to you. So I just wanted to give that caveat. So endocrinologists, endocrinology, hormones and glands, I thought I'd start with that. So a hormone is a chemical messenger that kind of travels around the body from one cell to another. And endocrinology is the study of those hormones. So as an endocrinologist, so a doctor that has an interest in hormones, I treat, in theory, any person that has a problem related to hormones. Now, within any specialty, we then kind of specialize into certain other things. So, for example, as you've already heard, diabetes actually is often, I've trained in diabetes, but then since I've become a consultant, I haven't actually practiced my diabetes knowledge that much. I can give general diabetes advice, but I'm not a specialist. So that's why we gave that caveat at the beginning that I won't be speaking about diabetes. So hormones are released or secreted by one part of the body, but they travel around our whole body in our bloodstream, and they can have an effect on another part of the body. And that's kind of how they're the messenger. And it helps different parts of the bodies in the human body kind of communicate with each other. Now, hormones are secreted by the endocrine glands, and the common ones I'll show you in a little map in a minute, but they're commonly the pituitary, so that's a gland in the head, the thyroid, which we all have in our neck, or the adrenal glands. So that's the common ones, but obviously neuroendocrine tumors kind of are endocrine cells and endocrine glands, and they've come in, but they're incredibly a small proportion of our work. So hormones are actually found in any organism that's more than one cell. So we're not special from a plant or an animal. They all have hormones too, and they influence or control a wide range of physiological activities such as growth, development, puberty, how alert we are, how we regulate sugar, so for the diabetes, how we regulate our appetite, how our bones grow, everything. So you'll also find that problems with hormones and the way they contribute are like a major problem in humans. So I've already mentioned diabetes, but the other ones that you'll commonly have heard of are thyroid conditions or pituitary conditions, or problems with sexual problems. So difficulty getting erections can sometimes be due to just lack of testosterone, or the menopause can be problems with hormones. It's kind of a big part of all of our everyday activity. The way doctors train, so I think it's important to understand that as an endocrinologist, I've trained in general medicine, so I'm not a surgeon and you don't want me operating on you. And then I've subspecialized into diabetes and endocrinology. And then in endocrinology, I've gone into even more detail in neuroendocrine tumors. So that's kind of where I come from. And I also do thyroid and thyroid cancer. And that's where I come from, my medullary thyroid cancer. So some people might be on this because they have medullary thyroid cancer. So those are kind of the broad bits that I've kind of subspecialized in within endocrinology. And each of your doctors may have picked something else that's different from mine. So these, I know it's very basic, but I love pictures. So these are all the endocrine glands that I think are the main ones. So from the top all the way to the bottom, we've got the pituitary gland. Let's see if I can focus. So the pituitary gland I've already spoken about, but above that, the pineal gland, literally just above the pituitary gland. So the pituitary is kind of a little chickpea-sized gland that sits kind of between these 2 points in the middle of your head, just below your eye nerve. Above that is the hypothalamus that sends messages to the pituitary. And the pituitary I kind of think of as the big computer messenger. And the pituitary gland sends messages to the other ones to work. So it'll send a message to the thyroid to work, a message to the ovaries or the testicles to work, or a message to the adrenal glands. And so the pituitary, the thyroid, the adrenal glands, and the ovaries or testicles are kind of all linked together. And the other ones are not so linked, they're independent. So that's kind of something that's important to know. For example, the thyroid may be linked to the pituitary, but on the thyroid, you may have heard of parathyroid glands, and we all have 4 parathyroid glands that sit on our thyroid, and they're not related to the thyroid, they're completely independent to the thyroid. I can't see if there's questions, so I'm just going to keep talking, if that's all right. So all these glands kind of form the endocrine system, and the important thing to remember is that there are other things that are commonly given the word gland, like sweat gland, but they're not what we call within the endocrine system, so they're separate to this. Good. This one. So as already said, a hormone is a chemical messenger signal that goes from normally one gland to another gland, and it kind of is a communication, is the best way to talk about it. If it's not going to a gland, it's going to go to a tissue. Now, I've kind of tried here to include all the hormones that I could think of quickly, and I've got this off the society, my Endocrine Society's website, because I think it's nearly inclusive. I'm sure there's probably one missing, and the urine 5-HIA, so our 5-HIA serotonin that we use in NET was missing. But apart from that, you can see it's already quite a large list of hormones there. But I've picked the thyroid one because that's one of the ones I'm most interested in, and it does come back to the medullary thyroid people towards the end. So the thyroid gland kind of sits here in the middle of our neck, and it makes 3 key hormones. So the predominant one is the T4, but it also makes T3 and calcitonin, and these go all the way around the body and have different actions on all the different organs that they touch, and are secreted to different volumes. Let me see what answer I was going to just say on the way. I think that's that one. So hormones kind of are really important that they're in balance, but you also need to understand what they naturally do. So they can vary through time of the day. They vary when we're unwell or ill, but they also vary when we age. So for example, I've got this one here shows what happens. Sorry, I'm using 2 screens. This graph here shows what happens as we age with regards to growth hormone. So this is a hormone we all make, hopefully to the right amount and not too much. If you make too much growth hormone, you may have heard of something called gigantism, or then if you get it as an adult, acromegaly. So they're making too much of a hormone. But we naturally make some as a child, And then as we age and we go through puberty, it significantly increases and then it drops, but we do make it the whole of our life. So that's kind of a hormone that changes specifically over decades. And then this other graph here I've got is a hormone that changes through time of the day. So this is our cortisol hormone. So it's naturally very low when we're asleep because it's part of our kind of clock that we don't need our get up and go hormone when we're asleep. But then just before we wake up, the hormone is secreted. It peaks as we wake up and then it naturally kind of drops down slowly through the day. And if I'd caught all the picture, it would have carried on falling. But this more complicated picture at the top here is just to show you that some hormones actually change every month. So obviously women are very used to our menstrual cycle, but in that there's a complicated process of estradiol going up and down, and then LH, which is a hormone, progesterone and FSH all fluctuating in that month cycle. So depending on your hormone, all I wanted really to get across here is you need to know what's normal for that hormone to know if it's actually doing something wrong. But that, depending on your hormone, you need to know what it should normally be, at whether it changes time of day, year, or the time of the month. So hopefully that's showing that. The other thing with the balance of hormones is you can actually, in all of the hormones, make too much of something or too little. And the commonest by far is the thyroid hormones are misbehave. So if you make something not enough, it's low, so it's hypo. But if you make something too much, it's high, called hyper. So in front of most of the hormones, you can either put hypo or hyper and then something at the end. So an overactive thyroid is hyperthyroidism, and an underactive thyroid is hypothyroidism. But actually this would work with most of the hormones. It's just often given, obviously, because doctors like complicated words and terminology, it might be given a slightly different word. But you can, for example, make not enough cortisol, so that would be hypocortisolemia, or too much cortisol, hypercortisolemia. It's just a long word to say too much or too little of a hormone. So I'm just going to switch again. So this is endocrinologist's role in an MDT. Now, there's lots of people in an MDT. So in an MDT, that's a multidisciplinary team. So that's a group of people that have a special interest, in this case, in neuroendocrine cancer. And I've stolen this, I'll be honest, from the Macmillan Cancer Support Team, and I've kind of added a few bits in that I thought were relevant. So I've listed them, I think, as importance to you as the patient. So the clinical specialist nurse is an expert nurse, obviously, who specializes in your condition, and probably in most of your cases is your point of contact with the team. The reason behind this is they're often continuity. They link between everyone that you need, and they know you a bit better than your doctor, and they know about your condition. So they're often, I would say, probably the #1 person important to you from the MDT. The next ones I think are useful are probably a radiologist and a pathologist. So your radiologist is the person, obviously, that gives you your scan results and reports your scans, and they can look at the scans and tell us whether things are stable or whether they've progressed or they've gone from your surgery, for example. The pathologist is the person that looks at whatever tissue's been removed and tells us the diagnosis. So that's all quite useful. The surgeon, again, very important. Ideally, we would remove any cancer type if we could. So they're the person that does your operation. And then the next group kind of depend on how your team at your hospital is set up. So you'll have a medical oncologist, that's a doctor that would give drugs, and a clinical oncologist, which would be a doctor that gives radiotherapy. So in this case, that would be the person that gives PRRT, or you might have heard it called magic bullet, or lutetium and yttrium treatment. So there's often 2 separate oncologists on a NET MDT. And then there'll be other people with interests in neuroendocrine tumors. So in Oxford, we have 2 endocrinologists. So we're both interested in patients that have tumors that kind of make these hormones. So we come because of the hormone excess. Gastroenterologists, because some of our neuroendocrine patients are kind of found through endoscopy or have gastric acid secretion as part of their pancreatic or stomach neuroendocrine tumor. So all of us come with a skill and are involved in the MDT, but we might not always be involved in your direct patient care, because it's what's needed for you at that point in time. So I might have missed off other people, but there I'd say the key people that we have involved. But occasionally we might go to a cardiologist, for example, if we've got carcinoid heart disease, and bring them into a smaller MDT for that specific patient, but they wouldn't necessarily be on the core MDT. And I think these people, I would say, probably are on the core MDT. So as an endocrinologist, the people that I probably am most involved in are the long-term surveillance of those with neuroendocrine tumors. And that's because I think that role can actually vary between how your team's set up. So in Oxford, it is provided by the endocrinologist, but I trained in Birmingham, and a gastroenterologist was the person that provided the surveillance of people that were kind of just ticking along and coming for annual scans once they've had their initial treatment. But the main people I would then be involved with are those with carcinoid syndrome. So it's a term that, as a doctor, for me, that means that that patient makes too much of a hormone called 5-HIA or serotonin, and I can pick that up often, depending on your hospital, on a spot or 24-hour urine sample. But the symptoms that you as a patient might experience are flushing, so typically facial flushing, often dry, diarrhea, are the key ones, and that might be why your doctors ask you whether you have those features. It's typically from patients that are small bowel neuroendocrine tumors, occasionally can be from lung neuroendocrine tumors, but it is not a condition associated with pancreatic neuroendocrine tumors. So that the carcinoid syndrome is not the pancreatic nets, but there are other neuroendocrine tumors that make the hormone 5-HIA, and that causes carcinoid syndrome. I think the next group of neuroendocrine tumors that I would probably say are my next biggest group are insulinomas. So these are on your pancreas, you have a nodule that makes too much insulin. So rather than diabetes where you don't have enough, in this case, you're making too much insulin inappropriately. And the consequence of making too much insulin is your blood glucose level falls, and you get what we call a hypoglycemic episode, so a low blood glucose. And so obviously that, if you don't keep eating to keep your blood sugar up, will cause problems, and that in turn causes weight gain and various other symptoms, to name but a few. So insulinomas, or patients that have insulinomas in part of their history, probably are the second biggest group that I have with neuroendocrine tumors. In Oxford, we also have in our NETs team all our pheochromocytomas. So it's a very long word, but it basically means you make too much of the adrenaline hormone from a nodule or lump within the adrenal gland. And these can be on one side or both sides. So the adrenals kind of sit just above your kidneys at your back on both sides, and they're tiny little glands, and they do make important hormones. But if they make too much of the adrenaline hormone, that's what we call a pheochromocytoma. And a paraganglioma is a pheochromocytoma that's not in the adrenal gland. So that's probably, I would say on average, I'd see a couple of patients about those a week. But I'm going to come back to that a bit later. And then the final group that I see is probably medullary thyroid cancer. So this is a specific type of thyroid cancer where they make calcitonin, which is another hormone that I can monitor in the blood. And I guess that's another thing from endocrinologists. Our way of keeping an eye on you is normally with blood or urine markers. So we try and collect from you the hormone and measure it in the blood, and then we're watching the trend of that normally to see if it's going up or down. So medullary thyroid cancer is a cancer of the thyroid that makes you make calcitonin, and you would come under our care. So those are probably the key groups of patients that I see. So just in a little bit more detail, I was asked to pick a few of them. And I think because I see so many pheos and paragangliomas, I thought this would be an interesting one to show. So this is just a, sorry, this screen. This was just a picture. So these are the kidneys that we would have. So if you were to put your fist in your lumbar region on your back, that's kind of where they sit. But there's two tiny little triangular glands above them, which you can see kind of covered here around with white. So they really are quite small, and they're the adrenal glands, and that's where the adrenals sit. So as I said, a pheochromocytoma is lumps within these two glands, but a paraganglioma can actually happen anywhere within the body. And the Amend website is kind of the equivalent to the Neuroendocrine Cancer, your society's group for the people with pheos and paragangliomas. So pheo, I do struggle to say, pheochromocytoma is actually often abbreviated to pheo because it's so long and difficult to say. They are also incredibly rare, just like neuroendocrine tumors are rare. And paragangliomas, I would say, are even rarer. The majority of these patient groups, however, probably have about 25% of them, sorry, probably have a gene that abnormality, so something wrong with their genetics that is causing them to have these lumps. So that's probably something slightly different to neuroendocrine tumors, that they normally have a genetic cause that is causing them to have these lumps. Now, because they're making too much adrenaline, it's probably the best way to describe it is if you were just about to walk in front of a bus and get all of those symptoms, kind of the headache, the palpitations, the sweating, or just imagine standing and presenting in front of, 10,000 people. All of those symptoms are because your adrenaline level has come up. And that adrenaline is kind of what's happening to these patients, except it's normally constant. And so they might get headaches from the high blood pressure and kind of this feeling of impending doom in their chest. And when they lie down at night, they can feel their palpitations, and sometimes they can even feel them day to day. They might get panic attacks or be told that they're just being anxious. And I must admit, I've had a couple of people that, with the benefit of hindsight, you can say you haven't had anxiety, you have actually just had really quite high adrenaline levels, and that's the cause of it. And after the operation, when their adrenaline levels are much better, the anxiety has obviously gone away. So the symptoms are quite non-specific, but I guess if you sit as an endocrinologist, I'd say these are very much in keeping with, for me, with a pheochromocytoma. So they're symptoms that I would quiz my patients about when I see them in clinic. I guess it's important, just like with neuroendocrine tumors, though, to admit that there are a group of patients that come that we're picking up early because of the fact that we're just doing so many more scans nowadays. So I know that some of you will have been picked up because you were symptomatic from your neuroendocrine tumor, but there are an increasing group of patients that go through a scan, I don't know, for gallstones or for kidney stones, and come out with the diagnosis that you've got this rare cancer that no one knows much about, and you've got to wait for the MDT. And it's a bit like that. Some of our pheo patients come through, oh, you have a scan for your kidney, but you've actually got a lump on your adrenal, which you're not really sure that they were even there before you went through the scanner. And then they're sent on a similar pathway to a group of people that they have to wait to see. So there are some similarities with the NETs. Just coming back to neuroendocrine tumors, I thought it was appropriate to talk about carcinoid syndrome. I know I've already done this a bit. So these basically, again, you're making too much of a hormone that's causing a consequence. And as I've said, it was 5-HIAA. The typical ones, as I've mentioned, are those from the small bowel, is probably the commonest. And then the lung, I would say, is the next commonest group for the location of the neuroendocrine tumor. You normally wouldn't have carcinoid syndrome until you've got liver metastases, until your disease has spread to the liver. I wouldn't expect it to happen before that point. The problem with carcinoid syndrome is if you make too much 5-HIAA, you're at risk of it upsetting the valves within your heart. So the reason we watch for this is it's much easier to prevent the problem or to try and manage the problem before it causes all of its consequences. So the carcinoid syndrome, they're making this 5-HIAA, which to you may cause as a patient the flushing and the diarrhea. For us, we can pick it up in your blood, but damage it's doing to your heart valves in particular is it can make them a little bit leaky, is the best way to describe it. But you can get something called carcinoid heart syndrome. So that's why we're trying to really keep an eye on you. So we watch for you for symptoms. So people will ask you about this diarrhea and flushing. We keep an eye on your urine, but we're also kind of hopefully keeping an eye on complications. And some of you might go for heart scans specifically looking for this. And there's sometimes blood tests that each team does to look for. It's a specific marker that if it's high, might, depending on how your team's set up, some people will be getting echoes, so their heart scans, and some people will have a blood test to screen and then go for heart scans, and that'll be dependent on how your team is run. So I'm not sure how that will work for each of you. But the test that you'll all remember for this one is when you're asked to do a 24-hour urine or a spot urine. So that's what this test, this lovely urine test where you walk in with your bottles, this is what you're getting tested for. So carcinoid syndrome.